3 structures in your kid's mouth that just might be causing his picky eating. This special episode is brought to you by ThroatScope. ThroatScope, do you guys know about these? If you attended the American Speech Language Hearing Association's national conference last year, we all got one of these in our goodie bag. And man, are they awesome, right? Hey, and look, I intentionally wore a black shirt tonight because I want you to watch this little secret. Here we go. Watch. It lights up. Is that the coolest? So throat scopes, yeah, I know, aren't they great? Throat scopes actually light up the whole interior of the mouth, and they come with these disposable depressors that you can get a pack of 50. And watch this, everyone. They just pop right on and instantly light up. So you guys have the pleasure of seeing my beautiful oral cavity right now, my mouth, because I want to show you how well this works. Look. I barely even have to press down on a kid's tongue when I'm using these because it just illuminates the entire mouth. So let's talk about what I'm looking for when I'm looking in a child's mouth. There are probably, honestly, 30 different things, but I want to highlight 3 that might surprise you when it comes to picky eating. The first 2 are tonsils. Tonsils are tissues, as I think most people know, way in the back of the throat, and they look like little tiny balls in these kids, and right in between the 2 balls is your little punching bag that we call the uvula, right? Okay, and we think of those when we see opera singers on the cartoons, right? Their uvula vibrates. Well, these tonsils, we want to be careful that they don't get too close to that uvula and definitely don't touch each other because A, the kids can't breathe, and B, it makes it really uncomfortable to swallow foods. So ask yourself, if your child is stuck on chicken nuggets, those are really just chopped up pieces of chicken that they breaded and fried or baked. You really don't even need teeth for those things. You kind of squish and swallow, right? They just break apart in your mouth. Are they stuck on fish crackers that just melt away? Are they stuck on, let's see, things like yogurts or macaroni and cheese? Because again, you don't even need teeth for macaroni and cheese, to be honest with you, or not too many. It just slides right down your throat. I've noticed, especially my older kids who are, say, 5, 6, 7, or 8, if they're still stuck on those foods, man, one of the first things I look for are those tonsils. Are they too big? Is there not enough space between them to allow food to comfortably pass? Now, if you're asking yourself, you know what, my kid eats big old fat bagels and does just fine, you also have to consider what certain foods are made out of. Not only will they have that slip factor because of a cheesy sauce or the fact that they've been dipped in ranch dressing, but also because they have a lot of gluten in them. So my friend Erin, who happens to be watching tonight, is the one who pointed that out to me one time when I called her up and I said, I've got this kid and he's got these really big tonsils. They're almost touching. He's a super picky eater. And I've been working with him for 3 or 4 months. But I'm really wondering about his ability to swallow. But he can eat a thing like a bagel. And she's the one who pointed out to me, Mel, have you ever taken a look at a piece of bagel after it's been in your mouth and chewed on it a couple times? It's really slimy. And that's because of all the gluten. Isn't that just, feeding therapists love that kind of stuff. It's like, yeah, detective work here. It's because of all the gluten that it gets that coating and the kids can just swallow those big old chunks of bagel down. So for parents listening, that's why I really want to encourage you to consult with a pediatric feeding specialist. That could be a speech language pathologist or an occupational therapist. And sometimes a registered dietitian will come into the picture with both of those professionals. An OT or an SLP, their expertise is skill, especially oral motor skill and feeding skills. So if you want to know more about that, let me show you with my own little cool throat scope here, that when you're looking in a child's mouth and you're looking into the pharynx, we call it, the very back of the throat. You can see my uvula hanging down, but you can't even see my tonsils. That's because at my age, they've actually atrophied and you barely even know they're there. But you'll see big round pockets of tissue, or I should say, excuse me, I should say pillows of tissue that your child will have in the back of their throat. Here's the other thing I want you to watch for. Not only how close they are, but is one bigger than the other? That asymmetry can also cause a lot of discomfort with swallowing. What it really comes down to is eating, sleeping, and breathing. Kids who snore, they sleep restlessly, or they frequently resort to just breathing through their mouth. Those are the kids who will often get strep infections, or even if your kid doesn't do any of those and he's having frequent strep infections, we really need to talk to the ENT about the size of their tonsils. However, ENTs are not feeding specialists. So that's where a combined approach of someone who can go and watch your child eat, maybe do a few sessions with them and figure out how much function might be impaired by something like tonsils. That's good information for that ENT to have. All right, let's talk about another structure that we definitely want to be concerned about, and that is a misaligned bite. So watch this for a second, because I can't talk and demonstrate at the same time. So just watch me for a second. I'm going to close my teeth, okay? And then I'm going to take my throat scope and what I'm doing is I'm just looking in the lateral margins, the lateral sulci, we call them, and we're just looking inside here to determine whether those teeth are right on top of each other. Are they a little bit misaligned? Do they overlap in kind of a different sort of way? Does your child have a crossbite? Do they have quite the gap between their top teeth and their lower teeth? Maybe they were thumb suckers. Maybe they were on a sippy cup for a really long time, which is really similar to thumb sucking. Or maybe they use their pacifier past the age of 1. If a child applies enough pressure to any of those structures in their mouth, thumb, passy, hard-spouted sippy cup, and they do it on a continual basis, they can actually change the way their palate, look guys, the roof of their mouth, the way their palate forms. And that in turn will begin to change the shape of their mouth and that aligned bite. We want a child to have a well-aligned bite even before they get older and they have to get perhaps braces. Even before that, because the way a baby's mouth is formed in the early stages of life will really help to prevent getting braces, but also if your teeth don't line up, you have a hard time chewing. There's just no doubt about it. And that can really lead to picky eating. Let me show you one more thing that I want to make sure everyone's aware of. One of the things you'll often hear me talk about is a tongue tie. And although I can't do a live exam on Facebook Live, because I need somebody to put my fingers underneath their tongue and actually do an exam, I'll include a couple links and a couple articles for you when I'm all done here in the comment section. But what I want to show you using my throat scope is do you see that little piece of tissue? That's called your frenum or your frenum. Some people say frenulum. And that little piece of tissue actually anchors the tongue to the floor of the mouth. It's supposed to attach right at the middle of the tongue and right at the middle of the floor of the mouth. If it attaches too far up front, or if it attaches or is embedded in the tongue itself, or if it's too short, it's too fibrous, it's too restrictive in terms of tongue movement, we consider that a tie. On one hand, we all have a frenulum, so we all have a tie, but in a speech therapy world, we consider it a tie when it's impacting function. And there is no doubt in my mind that if a child's tongue is being restricted, that he will limit the foods that he eats to more squish and swallow and easy to chew and easy to propel back foods. He will not eat things that require his tongue to do a lot of movement, a lot of control in his mouth, because he simply can't. The other issue with having a tongue tie and also being on a pacifier, a sippy cup, a sippy cup, a pacifier, a thumb. I was thinking fingers there for a minute because a lot of kids suck on their fingers. Is that what that does is, let's say that this little chewy is my thumb, so I can talk to it at the same time, okay? And let's say I'm sucking on my thumb, and so I've got it over my tongue as I suck on it. Not only will the pressure influence the shape of my palate and my dentition, but what it'll also do is it will prevent me as a 1-year-old from developing what we call a mature swallow pattern. Babies swallow, if this were a bottle, they swallow like this. It's a forward-backward movement. But about the age of 12 to 14 months, and it gradually gets more perfected by age 2, but about the age of 1 year, a baby develops what we call a mature swallow pattern. If they don't have their thumb, a sippy, a pacifier, a finger on top of their tongue a lot. So mature swallow pattern is when we, watch this, I'm gonna take a little drink of water. When we lift the tip of our tongue right there to the alveolar ridge, that's where we say a D or a T. See that? And then we squish our tongue up into our palate and we propel the food back. Kind of oversimplified, but that's basically it. So watch again. Easy peasy. But if you're a kid who still pushes your tongue forward because you were never allowed to get your tongue tip up because of digit sucking, etc., you swallow like this. That's a little tongue thrust. And man, can it make it hard to learn to eat a variety of foods. Well, you know what else contributes to that? A tongue tie. Because when your tongue is being held down, you might be able to extend your tongue tip past the tip of your lip, but you really can't get the rest of your tongue up into the roof of your mouth. And that's where the swallow is most effective and efficient. We need our palate to squish our tongue up there to get the food to move back. That's why it's really important that someone is knowledgeable about how to examine for tongue tie as well as a lip tie. And I'm not going to go into lip ties here tonight, but I'm going to definitely include some articles in all the comments for you. Be sure to click on the hyperlinks in all of my articles. They'll take you to videos, research, etc., so that you can learn more. All right, now I just gave you 3 structures, didn't I? But I want to give you a little bonus tip. Another reason why I encourage all of my families to get a throat scope is because I want parents to be able to look in a child's mouth if their appetite suddenly goes down. A lot of times kids' appetite will drop a few days before they're going to get sick. And especially nowadays, you know, we're really concerned about measles, aren't we? And I don't know if all of you know this, but in the recent years, I've learned more about what we call Koplik spots or Koplik spots. And what those are they're little, they look like little spots, almost like a little white grain to sand with a red ring around them. And they're right here across from our first molar if we're about to get the measles. So before your child even develops a fever, you can use a device like a throat scope to light up, illuminate your child's mouth, and just look inside to see if you detect those spots. Again, it's like a tiny grain of white sand, and each one is surrounded by a little ring. They typically appear, about 2 or 3 days, maybe. It's hard to say, before the child actually gets the rash, and they'll occasionally extend all the way into the rest of the mucosa, but then they disappear after the rash develops. So Koplik spots or Koplik spots, K-O-P-L-I-K, those can be noted in at least 50 to 70% of patients with measles if the examination is timely. So another thing to think about.